what we're going to be talking about today is metabolic syndrome and what we can do about it. We're going to talk about ketamine, we're going to talk about buprenorphine, and we're going to talk about epigenetics. This is a lot of stuff in a short period of time. The epigenetics at the end is just a couple slides, but I just wanted to try to hit on a few high points. The reason that I chose these topics when Tim talked to me was that if I was trying to think of things that we're talking about on the unit now or stuff that you're hearing about in the media, and I just wanted to kind of talk a little bit about what the data was. It's around some of these treatments, for example, and then also talk about something we're probably going to be doing more of, which is buprenorphine. So that's kind of why I picked these different topics today. They're very disconnected, unlike my catatonia talk last year, which was all about a syndrome. This is a bunch of different smatterings of things today. So at the end of this, you should have a sense about the metabolic syndrome and how to treat it. Also have a sense about the opiate epidemic, and then ways we can potentially impact the epidemic that's certainly impacting our patients and the population at large. You also have a sense of the data or lack thereof for ketamine for the treatment of depression. And then we're going to talk just a tiny bit about epigenetics because it's a huge topic that's pretty complicated. So you just have a sense of like, what is that stuff? And what does it potentially relate to mental health? So that's what we're going to be doing during our time that we have today. So we're going to start with audience participation. I want you guys to give me a show of hands to what you think is the correct answer for this question. So the major cause of death for people with schizophrenia is lung cancer, suicide, diabetes, or coronary artery disease. So we're going to do it in an organized way. Show of hands, who thinks number one is, y'all are going to have to vote for something, just by the by. So commit. Anyone think it's lung cancer? Silence. No one thinks lung cancer. Do our patients with schizophrenia smoke more than other people? Yeah. For sure they do, yes. Suicide? So I'm guessing probably maybe a quarter of the room to a third of the room identifies suicide. Third, diabetes. So I'm seeing 1, 2 votes for diabetes, and coronary artery disease. Right, so more than half of you. So in fact, it is coronary artery disease. That's what patients die far and away from. Far, far, far and away. They die from coronary artery disease more than all the other. We spend a huge amount of time talking about suicide. There is increased risk of suicide compared to the general population, but that is not what kills patients most of the time. It's cardiovascular disease. The average lifespan for someone with chronic mental illness is around 49 or 50, and they die from heart disease all the time. Yes? Do you have a question?
I was just wondering how much that had changed after atypicals.
You are like a plant.
Oh.
You just hold on to that. You are good, you are good, you are good. Also, our patients do smoke more, right? So they do have issues with smoking. All of those things are problematic for our patients, but the thing that's most problematic is, in fact, the metabolic syndrome. And this rate has actually been increasing, not decreasing. So we're not, even though we're doing all this stuff with our patients, if you actually look at the cardiovascular risk for our patients with schizophrenia, it's actually getting worse. It's not getting better. That is clearly not what we're looking for, right? That is not the trend that we want to have happen with our patients. So why? First of all, we know that cigarette smoking is a cardiovascular risk, and our patients smoke more than the general population. Right, so that's going to be one of the risk factors that we can try to do something about, but it is a risk factor that's there. The second thing is our patients are like the rest of the country. Is this going up or down in the country?
Going up.
It's going up, right? So that's one of the things that contributes to the cardiovascular risk is that there's an increase in weight. And then the metabolic syndrome. So the metabolic syndrome, I think gets to what you're talking about, is some of the metabolic syndrome that you see associated for our patients is because of the medications that they're on, right? So do you guys remember the old days when we had Stelazine, Haldol, Thorazine, right? What happened when the atypical or the second generation antipsychotics hit the market? What happened to people that were on the old antipsychotics? Did they get switched? Did they stay on the old ones? Do you guys remember this?
I'm guessing.
When they came, everybody got switched to an atypical because it's like, oh my God, those typical antipsychotics are terrible. You have got to get patients off those awful old bad drugs. Yes, movement disorders are associated with the typical antipsychotics. These are not benign drugs. You can have elevations in prolactin, so you can have galactorrhea, abnormal menstrual cycles, all kinds of sexual dysfunction that are associated with typical antipsychotics. They were not great drugs. So when the atypicals came out, there was a huge stampede, and patients got taken off of typicals and got put on the atypical antipsychotics. And you guys, when I'm saying typical, atypical, this is familiar with you guys, so this is, I want to make sure that I'm talking stuff that makes sense. So, this is the metabolic syndrome that you associate. Weight gain, dyslipidemia, and abnormal glucose metabolism. So if you guys think of atypical antipsychotics and you think about weight gain, which are the worst? Olanzapine, Zyprexa is its other name. Yep, that's by far and away the worst. Other ones that have weight gain associated with them?
Does risperidone?
Risperidone does. It's even Clozaril does, and even exactly Clozaril, quetiapine, Zyprexa. All of those do.
And in another category, Depakote.
And Depakote, which is not an antipsychotic, but absolutely. And then if you have someone on the combination of Depakote and olanzapine, holy moly, right? So lots of weight gain associated with that. Which antipsychotics are weight neutral? Which have no weight gain associated with them? Abilify and Geodon. Ziprasidone. Latuda has a little bit of weight gain, less than some, but it also, so we have two medications in that class that have weight gain that are not associated with them. All of the rest do. So they're on medications that cause weight gain. And what's the most you guys have seen for a patient that has gained weight with olanzapine?
30 pounds in a month.
30 pounds in a month.
I know one girl gained 75 pounds in her hospitalization.
Right. So this is about, so I heard 30 pounds in a month. I remember a patient on the old 5 Center who was on a combination of Depakote and olanzapine, and she gained 30 pounds in a month, and it was stunning. It was like someone put a little air tube in her, and she just puffed up like every day. It was amazing. So patients that are going to go on to gain significant weight with olanzapine, the high weight gainers are the ones that tend to start gaining weight right away after you start the medication. So if you're if you have a patient on your team and you're noticing, oh my gosh, is the team aware? Like this person has put on 10, 15, 20 pounds in the last couple of weeks, really important for you to say something to the team, because you know how the team is. They're thinking, the doc part of the team is thinking about all kinds of things. They may not actually be paying attention and realize that the person has gained that much weight, and there may be things that they need to do to intervene, which we'll talk about. Yeah.
Well, we'll see that sometimes. We kind of had a discussion, like, you know, we have these patients that will seek out food.
Right.
Just incredibly, they'll go through the trays.
Right. Yes, they will.
And they clean them off, and it's like, you know, we're going to have, this is my 600-pound life person. Right. But they're here for getting their mental illness. And we can't restrict the food because we have food available for everyone.
Sure.
I have thought about it, but how can you control it?
So a couple of things. One, the mechanism associated with the weight gain is in part secondary to an increase in appetite for some patients. For other patients, it is. For other patients, there's actual central action that makes them gain weight. But other patients, they will tell you, it's like, how's your appetite? Oh my gosh, I can't stop eating. I'm hungry from morning to night. I wake up in the middle of the night, I'm hungry.
Well, we're creating this other problem.
So the question is then, for patients that are really struggling with that, have we really exhausted other options? What happens is patients often get started on olanzapine, Zyprexa, initially because it is agitating or sedating. It's sedating. So people come in all agitado. We start them on olanzapine because it quiets them quickly. And then the trap is the patient starts looking better, and then it's like, should I change them? Should I not change them? If I change them, they may have a longer hospital stay, and they may destabilize. So I think one of the things we need to be thinking about are there better options or ways that we could optimize their treatment using different meds, or actually doing something if they're having a side effect of weight gain, which we'll talk about. So I think it's a real thing, and understanding that the patients really can't help it. Like for some patients, they get it's just like all they can do is think about food.
Right,
but if that's the case,
well, and weight, they can't get clothes that fit.
And it contributes to dyslipidemia. So some of the antipsychotics themselves, olanzapine's one, quetiapine's another, risperidone to some extent, cause changes in lipids. So they make the good cholesterol go down, the bad cholesterol go up, and their triglycerides go up, which is another risk factor for heart disease, right? And then it also causes abnormal glucose metabolism. So you can see abnormal glucose metabolism. Sometimes it's related to the weight gain, and when people have adipose fat tissue is more insulin resistant. But even people who stay skinny mini can still have abnormal glucose metabolism. Yeah.
Or so many times we're also now seeing metformin regime now.
Exactly right. So hold on to that thought, Bobby. I'm like at the plants over here. This is just impressive. Anyway, so I want to, clearly, this is something that you guys are very well aware that we're seeing on the unit, right? The metabolic syndrome. So what can be done about it? First of all, do not throw out the behavioral interventions. People never thought that patients could stop smoking. Like, oh, these patients are never going to stop smoking. Right. They actually can stop smoking. If you counsel them, you give them support, they can stop smoking. These patients can also make diet modifications. So there's studies that have looked at for people that have metabolic syndrome, trying to intervene by doing individual or group therapy, specifically focus on cognitive behavior therapy, using nutritional counseling. These are all fantastic things that we should not forget about by just thinking, let's just give them a pill. But also realizing sometimes we try these things and we're not getting where we need to get, right? You guys all know this. How easy is it to change your dietary habits? Your habits in general, your exercise habits, all those kind of things, right? It's really easy to say. Tim is holding up a bag of Ruffle potato chips for all of in the back, just to let you know, for an example of diet habits.
That's captured on camera.
There you go. So again, don't forget about these things, but I think sometimes we're not getting where we need to go, and then you need to think about pharmacologic strategies. The first pharmacologic strategies we need to think about, is there any way we can use an agent that has a better side effect profile for the patient, right? So if you have a patient who has some issues with depression, psychosis isn't so bad, maybe aripiprazole, you could get away with using that, right? It's weight neutral, it comes in a depot form. Maybe I don't need to have someone on quetiapine or olanzapine, which is going to have more weight gain associated with it. So I think that's one of the things to think about is, can we consider other agents and still have the patient be psychiatrically stable? So that's one thing. The second thing is, we can think about metformin. Thank you, Bobby. So you guys know metformin, yeah? Mm-hmm. Yeah, so you're very familiar with metformin. So metformin is the first-line treatment for type 2 diabetes, so non-insulin dependent diabetes. This is a great treatment for this. It helps the liver by reducing the amount of gluconeogenesis, so it tells the liver not to make so much sugar. That's one way that metformin works. The second way that metformin works is it actually helps the peripheral tissues utilize sugar better, so it becomes more responsive to insulin, so that also helps pull the sugar out of the blood, helps reduce the blood sugar. It also actually suppresses appetite, which is a third thing that can be helpful when someone's trying to regulate their blood sugars. And it can be used to treat the metabolic syndrome. The reason that I actually wanted to talk about this with you all is we're starting to use this more and more on the inpatient unit. And I remember one morning we were chit-chatting with a patient, and the patient had said, I refused that medicine that you started. We had started metformin on the patient. And we said, well, why didn't you take it last night? We want to understand, why the patient didn't want to do it. And he said, because I'm not diabetic. And I asked the nurse what this medicine was for, and the nurse said, well, this is a medicine that's given for diabetes, which is absolutely true. But we also are now using it in our folks to reduce metabolic syndrome. So when you give it to people that have, this is studies that have looked at antipsychotic induced metabolic syndrome, right? So these are people that have the metabolic syndrome because of the medications that we've been prescribing them. So it reduces insulin resistance, so it causes them to utilize the sugar that they have in their system better, just like it does with people with diabetes. It helps improve the dyslipidemia, so it actually helps improve the lipid abnormalities that you see. Great, right? These are both things that reduce cardiovascular risk. And it helps actually reduce the weight that our patients gain. But the weight gain appears to be more effective if you actually catch it before it has happened rather than trying to start it after the person has gained a bunch of weight. If you look at the data, once the weight is there, maybe it's going to help reduce the amount that they gain in the future, but it doesn't do much for what they've already gained. So I think a take-home is to keep in mind that if you have a patient and you're starting to notice this person seems to be gaining weight, first talking to the team about, hey, is there any way we could be thinking about a different antipsychotic for this patient because I'm really seeing their weight going up? Or can we start metformin on this person? Can we think about doing that with this patient? Because we want to catch it before it actually happens. Because this is what the person's probably going to die from, not from the other things that we commonly think of. So, questions about that before we move on? You guys have been good about jumping in. Yes?
Well, I have a patient that I was asking, how's your appetite, how's your sleep? And he goes, oh, I'm just really eating all the time. And he laughed and he said, I guess I needed to gain some of the weight. And I think he was on Zyprexa. I don't remember for sure. But we talked about it's easy. He said, it's really easy here because there's all this food. And I said, yes, but this may be related to, and it may continue after you leave.
Right.
And while you're here, you can practice dealing with that.
Right.
You can, consider using water or exercise and 22 times around this mile. Right. And he told me a couple days later, yeah, I'm looking at that because I don't want to have to deal with it later.
Exactly.
Not everybody is going to, but we were talking about implicit bias and
well, exactly, and that's that whole thing. It's like when I talked before, it's like don't forget about this stuff, right? There are behavioral innovations, and there are a subset of patients who really will respond to this, and they get practice while they're in the hospital. You can ask them, so how did you do on your menu this morning? How did you order double portions again? Did you eat I call it the lumberjack breakfast, like the piles of food they give our patients. It's like it's too much, right? So asking them, reviewing their menu with them, having them practice, meeting with the dietitian, doing all of these things. Because there's a subset of patients who are really going to respond well to this. And getting to practice while they have the support, find out what worked, what didn't work, teaching them healthy habits while they're in the hospital, what great modeling. Right? It's kind of part of that whole idea of like the whole person rather than just, the pill. Okay. So now we're going to shift gears. Special K, also known as vitamin K, super K, also known as what? Ketamine, right. So I'm going to actually read you guys something that I printed off from the internet. This is a ketamine trip that a person took. It makes your body feel buzzing, numbed, and tingling in a good way. Your sense of distance and time are very messed up. Vision becomes blurred, covered in static that is colorful at times, especially with eyes closed, and it might double up. It slows down and the number of frames slow down and you might see tracers. Not like the classic psychedelic, but on a higher dose, definitely quite an intense effect. If you take a sufficiently high dose, your senses will be blocked off and you will experience an inner world much like that of lucid dreaming. This is where people have the out-of-body experiences. You might also feel moving, tilting over, spinning, but not in a dizzying way, especially with eyes closed. You may not know what is up, right, left, right, down, distant, future, past, meaning, reality, you, what it means to be human. That's an example of a ketamine trip that I pulled offline. So, ketamine was created in 1962 and was started to use on humans in 1965 as anesthetic. So it's a dissociative anesthetic that is used. They used it a lot in Vietnam because it's pretty quick to turnaround time, pretty safe to use. By 1970s, it was actually being used as a recreational drug. And what people call it when they go through, you guys have heard of it, the keyhole, right? They'll call it the K-hole, going through the K-hole, and they have this experience. And more recently, it's getting a lot of press about robust antidepressant benefits. So all of you, I'm guessing, or most of you have heard about ketamine and the use of depression. Have any of you? Yeah, so a couple of you have. So there's more and more hype about this right now. So is ketamine, in fact, the little pot of gold at the end of the depression rainbow? Right? So you think about how good are we at treating depression now? How many of our patients that are getting treated for depression end up back in the hospital because they're suicidal and depressed? A ton, right? We're not that good at treating depression. We're not that good at it. We have lots of different medications, but
on the inpatient basis.
On the inpatient, there's a lot of on the outpatient, right? That's true. So we see a skewed population, but we also see a skewed population of schizophrenics. There's tons of schizophrenic people, bipolar people, who never get hospitalized. Very stable. We see the sickest of the sick where we're at. So are there side effects associated with the antidepressant treatments that we have, right? So there's problems, right? So maybe ketamine is going to be the pot at the end of the gold at the end of the rainbow. Or, what is that? That's a crackpot. Maybe it's actually just a whole crock. So do you guys recognize who's behind this?
Bugs Bunny.
My hero. I always put cute kitty pictures whenever I can and Bugs Bunny pictures whenever I can, because Bugs Bunny is awesome. So if you look at the data, antidepressants take time, right? Whenever you talk to a patient, you say it's going to be a 4 to 6 week lag time before this is actually going to help you in any way. Part of the lag time is that antidepressants actually aren't going to work on the receptor itself, right? SSRIs, selective serotonin reuptake inhibitors. What they're doing is reducing how quickly the nerve ending pulls serotonin back into the nerve where it has no activity, where it's packed into little vesicles. It lets more of it float around in the soup of our central nervous system that then can go act on the receptor, right? The same with venlafaxine, Effexor, right? You're increasing the amount of neurotransmitters that are floating around. All of these work in a similar way, that they increase the amount of bioactive amines that then go on to work on the receptor. So there's a delay, right? It takes time for those things to build up. Ketamine works directly at the site of the receptor. So the thought is there's no delay, because it doesn't have to build up. It just gloms on right away, just like benzodiazepines do, for example, when they grab onto a GABA receptor. So what the data shows, there are 7 randomized controlled trials with a total of 147 patients that this data is based on. Let me repeat that. 147 patients in randomized controlled trials. Is that a lot or a little? It's nothing. It's un poquito, right? It's a tiny, tiny bit. There's lots of case reports, lots of open label stuff. But what's the problem with open label stuff? It's an N of 1 or 2 or 3, and the patient knows what they're getting, and the provider knows what they're getting. So there's a lot of bias. So it's very, very hard to interpret that data. So if you look at these juicy randomized control trials, they found, in fact, in more than 50 people had a robust response. Like, they will tell you minutes to hours that their depression feels significantly better. No delay, right? But by day 14, Barb, to get to your point, the response is left in 11% of patients. So there's an intense reaction, and it fades quite quickly. It's a single dose infusion, right? So people can have a big bang for their buck, but the problem is it doesn't last. This is not FDA approved for depression. This does not have an FDA approval yet. It's approved as an anesthetic. Yes?
So if you give them that ketamine, and by day 14, they're not having as big a response, but you've started them on this other antidepressant that may be starting to kick in, or a series of ketamine.
So you could, or the question is like, true, you could kind of kickstart things, but so this is an interesting idea with no data behind it. And if you think about most of the time when people go to ketamine, do you think they've been on antidepressant trials previously? Probably, so they probably have kind of gone through most of their treatments. Maybe that is someday what we'll be doing. Maybe it'll be exactly what we need to do. The problem is we just don't have data to know at this point.
Kind of hard to have a...
Well, that's the point. That's the other thing that's a challenge, right? When someone is going to be getting ketamine, where are you going to give it? Yeah. Right? Well, I'll tell you, the ketamine clinics, which we'll talk about, and this will get to your point about frequency of dosing. So ketamine,
it's like accountable. It's a scheduled drug.
It's a controlled substance, right? And you also have to be like, can you bill insurance? Is this FDA approved? Not for this. Can you bill insurance? Absolutely not. Has that stopped ketamine clinics from popping up? No, right? In fact, someone who graduated from our residency has a ketamine clinic. So I have this for those of you that like peanuts. The doctor is in teaching, advice, and ketamine, 5 cents. So I typed in ketamine clinic Seattle, and in fact there are multiple ketamine clinics in Seattle that you can go to. I'm assuming it's cash on the barrelhead because they can't bill insurance for this. They say that you have to bring someone with you because you can't drive after you receive this because it's an anesthetic, right? So I think just because it isn't approved, there are patients out there that are receiving this, and we have no idea, like, how often should they get it? When is it that you should have too much ketamine? So if you actually look at the side effects, there's some bladder toxicity associated with it. There's a question that it actually is potentially neurotoxic and could cause cognitive deficits over time. We just don't know, right? It's an unknown thing at this point. The trip that I talked about that the patient was that the person was describing, that I read you kind of the K-hole thing from, this actually gets less intense for people with repeated infusions, so that feeling over there disconnected from their body, which for people who abuse the drug don't like that because you develop tolerance. But for other people that are trying to use it in a therapeutic way, it can be very uncomfortable. Some people really are not interested in actually having a psychedelic trip, right? And some of the trips, if you read them, are actually pretty scary. So for some patients, this also could be a problem because it may make them too uncomfortable in the treatment. The other thing about it, which you guys brought up, there's a risk of abuse or diversion, right? This is a street drug, in fact, in that people use it, they abuse it, and it has street value. So you always want to think about when you're starting to introduce a treatment, is this going to be an issue? Do I have to worry about risk of abuse or diversion? Like nitrous oxide, right? There's all kinds of controls about nitrous oxide because people use it in the OR, but people also can abuse it. So I just wanted you guys to be aware that we're going to hear more about this. This actually may be a treatment that's going to be very helpful for our patients, but I just don't think that there's enough data right now, which is why we actually haven't opened a ketamine clinic yet. We're still trying to figure it out. But I want you guys to be aware there's a buzz about this, and you may be seeing more about this.
Get FDA approval.
And let's get some FDA approval. So select the correct answer. The rate of death from drug overdose in the United States has surpassed that of motor vehicle accidents. The rate of opioid analgesic poisoning deaths has quadrupled from 1999 to 2011. The number of opioid analgesic overdoses involving benzodiazepines has increased 14% a year from 2006 to 2011. How many think number one? A couple? How many think number two? A couple? How about number three?
Seems like they could all be right with what we've been hearing.
They're all correct.
Oh, I was
Which is a trick, but it's like, but that, like, should that blow your socks off? That should blow your socks off. That's terrible. If you actually look at the data, this is deaths from motor vehicle accidents. It actually is starting to flatten out. Any idea why?
car safety.
What about cars that people are doing?
Seatbelts? Airbags?
No cell phone.
Cell phones. So the decline flattened for the first time in a very long time because it actually started to tick up because of the use of cell phones for people texting because God knows they got to talk on the phone. Exactly. So then you see this is from Opiate. Excuse me, drug poisoning and overdose. This one is all poisoning. Poisonings includes the other drugs. It also adds things like toxic fumes, other things. So it's poisoning of all kinds that can happen. So, but the vast majority of this, as you see, is actually related to drug overdose. So this is cocaine, heroin, benzodiazepines. So see how benzodiazepines, it's been going up, but what's really gone up? Opioids. Huge. No, heroin's pulled out from this. So this is from opioids. It's just gone up huge. So what happens when someone comes in the hospital and they're currently using opiates? What do? We withdraw them, right? So we use clonidine, we use antidiarrheals, we use antiemetics, usually we use something to help their muscles so they aren't having so much ache, right? So this is kind of the classic stuff we do. And the timeline depends on how their last use and also what kind they're using. So if someone's using methadone, someone using Oxycontin has a really long half-life, so it could take longer. Someone's using something short-acting, it can happen pretty quickly. So you're talking 7 to 14 days is what it can last if they're having a long half-life. Full intensity is 24 to 72 hours. How do the patients feel when they're in this state? Do they engage in treatment when they're in this state? No, right? So what ends up happening is we try to treat them by having them go through their withdrawal. They feel like crap. They don't engage in programming because they feel like crap. They're doing the best they can. They just feel really, really bad. So this is kind of what we do, right? Then we discharge them out of the hospital. The good thing is it's pretty safe to detox someone off of opiates. They're not going to have a seizure and die. They're not going to go through DTs like you can see with alcohol or benzos. The problem is more than 90% of the patients will relapse after they leave. and we've dropped their tolerance, right? They haven't been using, so then they go out and use what they normally use, and then they have an accidental overdose, right? So this is the cycle that we have gotten into. Houston, we have a problem. This is clear, it's not working. This is not, we're all working really hard. Patients are working really hard. It's not helping, right? So problem solving requires new approaches. So what we're thinking of doing now is doing more Suboxone. I just loved this slide, I have to say, when I found it. Suboxone, also known as buprenorphine, it partly sits on the opioid receptor and helps someone go through the withdrawal without actually getting a high associated with it. Unlike methadone, which is a full agonist, so methadone sits right on the opiate receptor, and the person actually, they do have it's like taking another opiate, right? It is an opiate that they take. So, and then naltrexone, as you guys know, completely blocks it, so that they don't get any benefit if they actually try to take opiates when they're taking naltrexone. The nice thing about buprenorphine, also known as Suboxone, is it helps people go through withdrawal much more quickly. Have any of you had a patient who came in who was going through opiate withdrawal who got Suboxone? How did they look? Barb, did you notice any difference? Do you remember?
Yeah.
They feel much better, much faster, right? So then they can do what? They can actually engage around their treatment. We can actually get them going and being part of the treatment. They have lower dropout rates when they're on Suboxone. The providers, however, have to be certified, and there's only a couple of us right now that are. I am not one, so we're planning to get certified in the next couple of months as a group. And there's an expansion in the outpatient program, because that's the other thing about Suboxone is they have to have buprenorphine. They have to have someone who can prescribe it after they leave the hospital. Otherwise, we've gone through this for no reason, right? We have to have a prescriber, and we're actually increasing the clinics that are available through the University of Washington that are doing this, which is going to be fantastic. And they still need to engage in outpatient CD programming, right? It's not like you just give them this pill and it fixes everything, but I think it gives them a fighting chance to actually be able to engage more. So you're going to be seeing more about this. So I just wanted you guys to know there's going to be more to come in the coming months. I would imagine by wintertime we're going to see a lot more of this being prescribed. And then we'll see how it goes. But I think it's actually going to be a really positive thing for our patients. So my last couple slides, and this is a now for something completely different. My last topic switch. You guys know what that's from? Oh, Monty Python. Oh, sad that some of you don't know. So, the genetics of psychiatric illness. I've only got 3 slides about this. At one point, people used to have this idea that we were going to find the schizophrenic gene, the bipolar gene, and in the Genome Project it became very clear that it is much more complicated than that. It's very likely that there will be groups of genes that together in specific combinations create the clinical pictures that we see. And it's not only that you have this collection of genes, but also there were environmental factors that influence the expression or suppression of some of the genes. So things that can upregulate or downregulate genes, that's what epigenetics is. When you're talking about the changing in the expression of genes on a gene-to-gene basis. And as a result of these changes, it can cause changes in both behavior and neuronal expression that you'll see in mental illness. So things like the bacteria in your gut, the diet that you're exposed to, stresses, infections, those actually change the things called DNA methylation and histone signature. Those are the things that actually impact whether genes are being expressed or suppressed. You'll hear more, you guys have probably seen some of this. They've been putting patients on probiotics on the inpatient unit. In part, that's because the thought is if we have abnormal gut flora, which some of our patients have, maybe somehow it's contributing in some way, but there is a lot we do not understand about this at this point. So I just wanted to mention this because some of you were like, what are they doing, putting these patients on these things? So I just wanted you to be aware that I think in the next 5 years or so, I think we're going to be hearing a lot more about this stuff. And I just wanted you guys to be aware that this is part about what's going on. Yeah.
Well, and also they're doing DNA checks now, tests for what antidepressants are sensitive to.
Right.
It's like $179.
Right.
I have a friend's daughter who just did it.
Yeah, so there's also genetic testing. The challenge with the genetic testing to determine which antidepressant is would be best or worst or not work for you. The data is not consistent yet, so you may get lucky and it may help, but I think we're a little bit further away than some of the companies that make money from that would have you believe. Yes?
Sorry, I know we're limited on time, but I'm very interested in the diet and the gut and those roles in mental illness. And
Yeah.
Are you able to recommend a location that we can turn to for guidelines or evidence on that?
I can send some links for articles. I'll get them to Tim, and then you can have some articles to look at, because there's some really interesting stuff that's come out on this. So I just wanted you guys to be aware that you're going to be hearing more about this, and I just wanted to kind of whet your appetite for it. And that's all. So, any other questions? I know it was a lot in a short period of time. No? Awesome. Thanks for you guys' attention. I'm going to get rid of my antenna, which I really am kind of a little attached to at this point. It's kind of fun.